So good evening, and thank you very much for inviting me to speak at this great conference. I'm from Ireland, and my country and your country have a long history. Once upon a time, we played against one another in the Soccer World Cup, but going back a lot further than that, the book you will see in the top right-hand corner is what we call in Ireland the Fadden Moor Psalter, which is a book that was found in a farm in Ireland about 10 years ago, which was actually printed on papyrus.
Can you speak slowly, please? Slowly.
Sure.
Because you are speaking, you have time. This is the last session.
Okay.
Okay,
So,
and the subject is really good.
Thank you. So the book in the top right corner was printed on papyrus, and it's estimated that it was brought from Greece to Ireland by monks in the 6th century. And even going back further than that, in 1,700 years BC, the Egyptian queen Scota came to live in Ireland and Scotland, and that's where we get the country name Scotland from. So there are great links between our countries. I'm here today to talk about fatigue and inflammatory bowel disease. Now, fatigue is a very commonly reported symptom, but you know, there is a difference between the type of fatigue we see as a medical problem and just the everyday fatigue people have. And we define that as a perception of generalized weakness, so inability or difficulty to initiate activities, quick fatigability, by which I mean reduced capacity to maintain activities. And the third aspect is mental fatigue, where people have a difficulty with concentration, emotional stability, and memory. And we recognize these symptoms frequently in our IBD patients. So what is the scale of the problem? Much of the best research we have on fatigue in IBD comes from the Netherlands. And the first really good study.
Can we have a shared screen? Can you share your screen with us?
I'm sharing, yeah.
It is not yet.
It's not coming up.
I'm sorry.
Yeah, it's okay. We go to Zoom. Is that better? Can you see that?
Yes.
Oh.
Thank you. Thank you.
All right, sorry. So much of the best data we have on fatigue and inflammatory bowel disease comes from the Netherlands. And this was the first study we really had that looked at it in a major way in 2003 that estimated more than 40% of IBD patients while in remission suffered from fatigue. And that when we look at the extent of that fatigue, it is comparable to somebody who had just completed cancer therapy. So this was a major development in this particular field of study. We've gotten a lot more data since then, and a systematic review and meta-analysis carried out earlier this year, looking at 20 studies of fatigue in IBD, estimates the global prevalence of fatigue in IBD at 47% of patients, with patients much more likely to be fatigued when their disease is active at 72%, compared to when in remission at 47%. The Swiss IBD group, which produce a lot of high quality IBD epidemiological research, recently did some work in fatigue, identifying what were the risk factors for it. They noted a prevalence of 55% of IBD patients with fatigue, with female gender, younger age at diagnosis, a shorter disease duration, nocturnal diarrhea, a low education level, and symptoms of depression and anxiety being strong predictors of a likelihood that a patient will suffer with fatigue. So fatigue is consistently rated by our patients as being both common and debilitating. It reduces health-related quality of life scores in almost all domains in both ulcerative colitis and Crohn's disease. And we know that that fatigue is every bit as intimately related with an impaired quality of life as disease activity. 70% of our IBD patients miss work for at least one day every year, and more than half report fatigue as the reason for them missing work. So there's a huge economic impact to this too. Fatigue is persistent for our IBD patients. At 6-month follow-up, only 1 in 8 IBD patients reporting fatigue will have resolution of their symptoms. And the strongest predictor of incident fatigue in patients who don't have it at baseline is sleep disturbance. There's been some research in recent years, again coming from the Netherlands, of what is the trajectory of patients who complain of fatigue and inflammatory bowel disease. And we note that about 11.4% of patients with Crohn's disease and about 5% of patients with ulcerative colitis will experience chronic levels of debilitating fatigue, and that women and parents were more prevalent in trajectories that had the higher fatigue severity. And again, these studies also endorse the association with both disease activity as well as psychological well-being. So what is the impact of fatigue on our patients? So this is a study that was done in the United States 10 years ago, where patients with IBD were asked to assess what aspects of their disease caused them the most amount of difficulty and worry. And by far and away, the physical symptom that leads to the most difficulty and worry for IBD patients is fatigue. It's the main concern for 60% of patients with Crohn's disease and 43% of patients with ulcerative colitis. Work and finances are also significantly impacted by fatigue. The United Kingdom Crohn's and Colitis Group estimate that more than half of their patients with Crohn's disease report it's difficult to remain employed because of the fatigue associated with their condition. Again, some more interesting work from the Netherlands this year shows that fatigue is the strongest determinant for loss of work productivity in employed IBD patients, which again leads to a significant financial impact on a group of patients who already suffer financial impact because of the costs of their disease and the costs of medications and hospital care and many other aspects. Interestingly, IBD-related surgery and vedolizumab use were also associated with work productivity loss in the ulcerative colitis subgroup. This is data from our country in Ireland, and we noticed that the symptom that bothers IBD patients the most by a considerable distance is fatigue, far ahead of abdominal pain, diarrhea, urgency, rectal pain, or incontinence. For both patients with ulcerative colitis and Crohn's disease, fatigue is the physical symptom with the biggest impact. But when we look at our IBD research community that we're all part of, what do we care about the most? So if you go back to 2018 and look at the most prestigious journals in our field, gut and gastroenterology, there were 28 original articles on inflammatory bowel disease. 13 were about basic science and 15 were about clinical science. But one thing they all had in common was none of them used a quality of life score as a primary endpoint. And some of the endpoints that were used were mucosal healing, steroid-free survival, level of drug in breast milk, CRP, drug and antibody levels. And all of these things are really important. And I think our last speaker, Alessandro, gave us a very good rundown on why mucosal healing and possibly even histological healing is very, very important. But the point I'm trying to make is that the patient experience is also important. And if we listen to our patients, what they are telling us consistently is that fatigue is the biggest physical problem for them. And I think we possibly need to afford it a little bit more energy in our research endeavors. But the good news is this is changing. And if you look at PubMed searches on fatigue in IBD, there have been more papers published on this topic in the last 3 years than in the entirety of history before that. So it's an area that is attracting more interest, and we're getting a better quality of data than we ever were before. This is some work that we did on when I worked in Leeds in the United Kingdom on clinical disease activity. And one of the points that we noted was that mucosal inflammation, even though we accept it's very, very important, does not correlate all that well with clinical disease activity. And that patients who experience remission, many of them will still have IBS type symptoms. They will also have psychological comorbidity and somatization, and their quality of life will be significantly reduced compared to patients who have either clinically quiescent disease or patients who have occult inflammation. And we note that the IBS type symptoms have a similar effect on psychological health and quality of life as do active disease. And then again, more work that my group did when we were in Leeds was looking at which patients reported fatigue. And one of the things we noted from that was that patients reporting fatigue is actually not directly linked to biochemical disease activity or anemia, and is actually far more likely to reflect the patient's mood and symptom reporting behavior than any of these objective parameters. So what does this prove? I think it proves three things. I think we can conclude that in inflammatory bowel disease, health is about more than mucosal healing and endoscopic remission. Also, we can conclude that the relationship between disease activity and fatigue is certainly not linear. And I think we can conclude that tackling fatigue offers the most direct way of improving the lives of all patients with IBD. So why do patients with IBD experience fatigue? So there are many reasons for this. If we look first of all at the physical, patients will be in a circulating pro-inflammatory state, and that's associated with fatigue. They may have nutritional deficiencies and anemia. They may be experiencing pain, which leads to fatigue. They may have short gut syndrome. They may be experiencing medication side effects, or they may have lost weight, all of which can contribute to fatigue. Similarly, there are psychological causes for fatigue. We know our IBD patients are more likely to struggle with depression and anxiety, and post-traumatic stress disorder, and loneliness and stigma and isolation. There are also lifestyle factors. We know that our IBD patients are more likely to miss work. So when they return to the workplace, they work harder to catch up and they push themselves too hard. Some IBD patients will go on fad diets and food avoidance diets, and this may result in poor diet leading to fatigue. Many of our IBD patients give up exercise, and this sedentary lifestyle can also contribute to fatigue, as can sleep deprivation. And then there are the social causes of fatigue. Our patients with IBD have financial worries. IBD causes difficulties in their personal life, and also they're more likely to have problems with unemployment and occupational stress. So to talk for a moment about nutritional deficiency and anemia. Anemia is very common in IBD, affecting 15 to 20% of our patients. And in up to 50% of cases, it's iron deficiency anemia. There are several reasons for this, including intestinal blood loss, malabsorption, altered metabolism and iron storage, and the suppression of EPO and iron binding by pro-inflammatory cytokines. Anemia is closely associated with fatigue in Crohn's disease. However, this does not necessarily appear to be the case in ulcerative colitis. For patients who are not anemic but have a measurable iron deficiency, correcting the iron deficiency without anemia will not alleviate fatigue and is likely to provoke adverse side effects. Similarly, replacing vitamin D, although it's very worthy for our IBD patients and important, is not going to resolve the patient's fatigue. So to speak about the circulating pro-inflammatory state, we know that even when the disease is quiescent and in remission, there's still elevated levels of pro-inflammatory cytokines such as IL-10, IL-12, stimulated TNF, and interferon. And in patients with fatigue also, we note significantly lower GCSF and GM-CSF and lymphotoxin A in patients with fatigue. So it appears that the metabolome may be where some of the answers lie. And another good study from the Netherlands, looking at a prospective cohort of 87 patients with IBD, suggested that when fatigue was present, 3 different metabolomic profiles were observed, and they were around pyrimidine metabolism, branch chain amino acid biosynthesis, and glyoxylate and dicarboxylate metabolism, all of which were noted to be affected in patients with fatigue. What of the microbiome and the gut-brain axis? Well, we know that our patients with IBD have a reduced microbiome diversity. And we also know that the gut microbiome has a direct effect on both the immune system and the hypothalamic pituitary adrenal axis. All of this can contribute to fatigue. When we look at data on patients with ME and chronic fatigue syndrome, we note that similar loss of microbiome diversity is seen in those conditions as is associated with IBD, including decreased firmicutes and increased elastipase and bacteroidase. So perhaps there's a microbiome link there between fatigue in IBD. Some more recent data that's very, very recent in the last month or two, again from the Dutch group looking at patients with fatigue, they found among 91 patients with fatigue that they didn't on this occasion find an increase in serum inflammatory cytokines, but they did find significant reductions in levels of methionine, tryptophan, and proline in patients who complained of fatigue. Looking at the stool microbiome of these patients, they also noted significant reductions in butyrate-producing bacteria, specifically F. prausnitzii and R. hominis. So there is emerging evidence of a fatigue-like microbiome, which is associated with increased scores on fatigue scales and correlates with progressive depletion of metabolites, such as tryptophan and methionine, from serum samples. Psychological comorbidity in sleep, again, is closely associated with fatigue in IBD. Depression occurs in 27% of IBD patients and anxiety in 32%. And these are consistently associated with fatigue in IBD. Similarly, with respect to sleep, we see a much higher incidence of disrupted and poor quality sleep in IBD, affecting most patients, compared to only about 1/3 of the general population. IBD treatments may also lead to fatigue. Thiopurines and steroids in particular are very frequently associated with fatigue, as is surgery. Anti-TNFs are usually helpful in measurements of fatigue, but one study did show increased fatigue with anti-TNF when compared to immunosuppressants, a study which has not been reproduced. So the next question really becomes, how do we assess fatigue? So numerous questionnaires and inventories have been used over the years in the literature to assess fatigue, and none of them were particularly satisfactory. Many of them were initially developed in cancer and chronic fatigue syndrome and other conditions. And this led the Crohn's and Colitis of the United Kingdom to devise their own Ibdf Self-Assessment scale. And this is what we use in our clinic and also in our research studies. And it has 3 sections. The first assesses the level and duration of fatigue. The second assesses the impact of a patient's fatigue on their daily activities. And the third is aimed at the patient to try to identify the causes and any other factors related to their fatigue. It's free to access online at that website, and I would recommend it's a very useful tool for you in clinic to separate out patients with true clinical fatigue from patients who may just be going through the ups and downs of life. Some research recently has looked at whether or not there are biomarkers of fatigue, and this from a Spanish group suggests that changes in the lipid profile may be associated with fatigue in IBD, but this is still very, very early research. How do we as doctors respond to our patients in IBD? This is a survey that was done in the United Kingdom, but certainly I think it probably reflects practice in many parts of the world. 92% of patients, on hearing a patient is fatigued, 92% of doctors will check the hemoglobin level and treat if low. When it goes to things beyond that, we're not very good. Only about 36% will advise on diet, exercise, and sleep. So clearly, even though, as I've demonstrated earlier, this is a huge problem for our patients, we're not very good at helping them to tackle it. So I'm going to focus now on some emerging interventions for fatigue. So the 8 interventions are, first of all, to review medications. I think we all do that. Secondly is to evaluate and replace nutrient deficiency. But there are some other interventions that I'd like to talk to you about. So the first thing is to optimize the patient's IBD treatment. I'm not suggesting that patients without objective signs of disease should have their immunosuppression increased because they have fatigue, but certainly in those borderline cases where we're not sure whether or not to escalate treatment, we should listen out for fatigue and whether or not the patient is reporting it, because if they are, there's a reasonable possibility that escalating the patient's level of disease-modifying treatment can improve their fatigue scores. What of psychological treatments? Well, most psychological treatments that have been examined in IBD for fatigue focus on mental health symptoms and have fatigue as a secondary or tertiary endpoint, and they use non-validated questionnaires. One study suggested less tiredness after a stress management program compared to treatment as usual. Another Dutch study suggested solution-focused therapy is effective in 85.7% of patients, and 60% was effective in problem-solving therapy in resolving the patient's fatigue. But all of those interventions are very expensive and time-consuming, and most IBD units in the world would not really have the wherewithal and the finances and resources to provide them. So this is a study that an RCT that I conducted again when I worked in Leeds, where we designed a very cheap and easy to implement psychoeducational tool, where we gave people 3 one-hour multidisciplinary interventions consisting of an occupational therapist with expertise in fatigue management, a psychology nurse, and an IBD nurse. And we looked at identifying the reasons for fatigue, equipping the patient with ways of controlling it themselves, and in the third session, equipping them with ways of dealing with relapse. And we noticed that when we did that, patients experienced a significant improvement in both the impact and severity of fatigue, and also improved scores in 8 out of 9 quality of life domains. And that we were able to run that for 25 patients with £7,000. So it's a cheap and easy intervention, and one that could be recommended. A systematic review conducted of psychological interventions, including the one I designed, found that the studies were small and largely underpowered, but also found that CBT was the most efficacious psychotherapy. But again, it is expensive and labor intensive to deliver. So another strategy can be to treat mood, sleep, and psychological disorders. Much of the information we have to guide us in this space comes from other disease areas. If we look at cancer fatigue, there is some evidence that the combination of dexamethasone and methylphenidate can help with cancer fatigue. In fatigue occurring with stroke and in chronic fatigue syndrome, sometimes psychostimulants and SSRIs have been proven effective. But unfortunately, in the IBD patient, what little information we have suggests a lack of efficacy for SSRI. A recent study again last year showed polysomnography of IBD patients shows altered sleep patterns and high rates of sleep fragmentation, even in quiescent disease. An interesting study that looked at combining a medication and psychological approach was conducted last year, which gave patients a brief cognitive behavioral therapy intervention for 4 weeks. And when that happened, we noted significant improvements in sleep quality and levels of fatigue. After 4 weeks, bupropion, an old-fashioned antidepressant, was added on for 2/3 of the patients, while 19 stayed on behavioral therapy only. And while both intervention groups saw further improvement in fatigue, anxiety, and depression, there did not appear to be any added benefit from adding in bupropion compared to continuing just with behavioral therapy alone. But I do think eventually when we get to the bottom of fatigue in IBD, it will be a multimodal approach, possibly combining therapy, medication, and diet in the microbiome. Physical exercise we know is helpful in IBD. Contracting skeletal muscles release biologically active myokines, which have direct anti-inflammatory effects. And also losing weight helps inhibit the release of pro-inflammatory mediators from visceral fat. But our patients who suffer with fatigue tend to stop exercising, so they need special help. This study, again from Holland this year, showed a personalized exercise program in IBD fatigue to be very effective. And this was designed based on the patient's own physical parameters. And they gave people 3 one-hour sessions in a week and found that fatigue and quality of life was significantly improved after completing the exercise program. And also that improvement was seen in emotional, systemic, and social function and cardiovascular fitness without any change in bowel symptoms. So this is a really good study. But again, it was a personalized exercise program. And unfortunately, these things are expensive and labor intensive and difficult to organize. This year, one of the most exciting developments in fatigue has been the first RCT that showed a clear benefit from a specific intervention using fatigue as a primary endpoint. And that was a crossover study of 40 patients with high-dose thiamine that was done in Denmark, suggesting a mean reduction of 4.5 points on fatigue severity compared to the standard of care group. So this was really a game-changing study and certainly has been practice changer for me, as the thiamine was very well tolerated with only mild side effects. Diet and probiotics have also been looked at. Again, from the cancer literature, there is some evidence for a fatigue reduction diet high in fruits, whole foods, vegetables, and omega-3. These have not been assessed yet in IBD fatigue, but certainly it's a study that will be welcomed. Dietary therapies for IBD have not been assessed for efficacy in fatigue. Regarding probiotics, in chronic fatigue syndrome, lactobacillus and bifidobacter have been shown to improve both neurocognitive function and anxiety in that particular condition. And then when we look at depression, patients taking lactobacillus and bifidobacter also seem to have a positive effect on their mood. IBD, however, obviously presents specific challenges around the use of probiotics in the microbiome. My lab is currently conducting 2 randomized control trials on probiotics for patients experiencing fatigue in IBD, one looking at a dual strain probiotic with fatigue as the primary endpoint in ulcerative colitis, and the other a 4-strain probiotic, which is a primary endpoint of controlling IBS symptoms in quiescent Crohn's disease, but has fatigue and quality of life as a secondary endpoint. And we're close to reporting that one, and we're hopeful of a good outcome. In summary, fatigue is consistently rated as the most troublesome symptom of inflammatory bowel disease. We have no examples of a multifaceted, multidisciplinary, evidence-based approach to managing fatigue in IBD. Strategies that may help and warrant investigation include thiamine supplementation, optimizing therapy, treating concurrent and associated psychological disorders, diet, exercise, and probiotics. The body of research is growing and breakthroughs are likely near. I know you missed my second slide, but I would really like to show it to you if you have a moment. And here's the lovely relationship between our 2 countries. If you look at the photograph in the top right-hand corner, that's an old Bible printed on papyrus in the 6th century. And papyrus was only found in Greece then. And it was found in a farm in Ireland 10 years ago, perfectly preserved in a field by a farmer. And the Egyptian monks that came over here in the 6th century were a huge source of inspiration and education to the Irish people. So we come back to thank you for that. And in the bottom left-hand corner, you see the Tomb of Scota, who was a famous Greek princess, Egyptian princess who came to Ireland and Scotland, and for whom the country Scotland is named after. So we have many connections with Egypt, and I'm delighted to be with you today. Thank you very much.